Okay, we're going to be talking about a bunch of cases in which ultrasound really helped avoid the misdiagnosis. And my name is Chris Fox, and I work at UC Irvine. And hopefully, everybody is not listening to this at home, but they're actually seeing me in person give the talk in Maui. But in case you couldn't make it, then you have the online content as well. All right, we'll get started. Before we get started, though, I love this ultrasound. We do this thing where we have ultrasound Doppler gangers, where an ultrasound looks like something else, and to us, this loop of bowel here with the little bowel obstructions, maybe some ascites around it here, looks like just a smiley face, little turd there in that left eye. Anyway, moving on. This was a patient. All these are real patients. These are all patients I was involved with. So, 22-year-old female. She was having an asthma attack witnessed by her next door neighbor. When the paramedics got there, she was like bradycardic, hypotensive, cyanotic. By the time they got her into the emergency department, she was basically in PA and coding, and it was really weird because like we heard asthma attack, and so we were, we had her intubated. She's really easy to bag and everything, and we didn't hear any wheezes. And then we knew that she was found outside in front of her house. And so that kind of got the medical student wondering, hey, maybe she was hit by a car. Maybe this is a trauma patient because she's found outside. And so we did a fast scan on the basis of that medical student's recommendation. And here was a wedge of fluid seen here in Morrison's pouch between the liver and the kidney. This is a really old ultrasound machine. This is one of my first cases ever. And so I just love this case so much. I always tell it. So then we cut the rest of the clothes off this patient and realized she doesn't have any other signs of trauma. Like there's no contusions, there's no bruises. It's like, why would this 22-year-old female have free fluid in Morrison's pouch, yet not have any signs of trauma? So then we started to wonder about ectopic pregnancy. And so we looked transabdominally, and then eventually we looked with the endovag probe, and we saw like blood basically extravasating in her pelvis over here. And so we can see like active bleeding down in her pelvis on this otherwise healthy 22-year-old female. And, there's maybe another, not on this image so much, but there's like another image where there was a mass and stuff. And so free fluid, active extravasation and a mass Morrison's pouch. Before we got the pregnancy test back, we had OBGYN at the bedside and took this patient to the operating room, and she survived. And so these ultrasound with ectopic pregnancy can be very, very impactful. This next patient is a 32-year-old female, Vietnamese. We have a large Vietnamese population around UC Irvine, and so a lot of times, either we have somebody who can translate, or in case when somebody's really sick, it gets they don't have a family member with them, it gets really difficult. So anyway, so she was hypotensive, and we couldn't tell if it was like a language barrier or not. We're waiting for the translator thing, and meanwhile her vital signs are like tachycardic, hypotensive. Her pulse ox was 94%, but she was at this point getting pretty much unresponsive, GCS of 3. So we intubate her, and we do an EFAST like as we're intubating her, and we see on this patient, we see also free fluid here, like that last patient in Morrison's pouch. And then it's the same thing. It's like this young woman we don't know anything about. We can't really get a history from, but she's got, peritoneal free fluid. And so we start to wonder, could this be an ectopic pregnancy? And we're using the transabdominal probe in this case, and we see in her pelvis this thick ring of ectopic pregnancy with a little fetal pole in it here. And the uterus is actually way over here. And so this pregnancy is lying outside the endometrial echo of the uterus. And, if you don't know that, if you don't like find your landmark, which is the uterus, you could easily mistake this as being like, oh yeah, there's the gestational sac, and, that's the fetal pole. And that all is true, except all of the stuff is outside the endometrial echo of the uterus. Here's another same patient here, and you can see the uterus is actually right here. There's there's like blood down here in the posterior cul-de-sac, and adjacent to everything is this mass with this thick tubal ring of ectopic pregnancy sitting out over here. So that kind of clinched the diagnosis, and she went to the operating room, and this patient also survived with a ruptured ectopic. And here is another patient. We have these triage shifts where we spend the first part of our shift out in triage, and it's just you're probably doing the same thing. It's like you're just seeing so many patients so quickly, and it's not in the ideal location. You're out in triage, but anyway, This 38-year-old woman came in with right lower quadrant abdominal pain and weakness for 1 day, history of diabetes. She's on metformin, hypotensive, tachycardic, and we get the urine pregnancy test. It turns out to be positive. Get out there, it's like a point of care test you do in triage, and the patient's like, what? I'm pregnant? I didn't know I was pregnant. And so with this right lower quadrant abdominal pain and some weakness and maybe some hypotension, tachycardia, pregnancy, we get very excited. And sure enough, she's got free fluid Morrison's pouch too. And we end up looking in her pelvis, and it starts to say the same picture. Here's her uterus over here. It's empty. There's free fluid back here in the posterior cul-de-sac. And here's this thick ring of ectopic pregnancy outside of the endometrial echo of the uterus. Just yet another reminder that ultrasound is really helpful, especially in the first trimester of pregnancy. And whether or not you are conscious or can speak to us, or we know what's going on, the ultrasound becomes the ultimate translator in that situation. So anyways, I promise you, we won't be talking any more about ectopic pregnancies the rest of this talk, but those 3 ectopics were pretty impressive. This is another large ectopic with, like fetal movement that's outside the endometrial echo of the uterus. Another good reason to always make sure you see both the uterus and the baby on the screen at the same time, so you can differentiate whether the baby is in the uterus or not. Okay, new patient, 52-year-old male, hypertension, coronary artery disease, AFib, on Coumadin, fever and hypotension. And this guy comes in history of CHF and poor LV function, and just basically fever, cough, tachycardic, hypotensive, little tachypnic, febrile, hypoxic, and he's on Coumadin. He even says to us, I'm a vasculopath. He uses those words. It's kind of funny. So nurse comes over and does an ultrasound-guided IV access. After all, he is a vasculopath. And, on the Coumadin and everything, you don't want to be poking around too much. And so she got that IV in the longitudinal axis there, and that got us our labs and our cultures. We got an X-ray. It gets read as bilateral patchy infiltrates versus CHF. And so then we have a medical student out there in triage, and the medical student goes ahead and performs an ultrasound of the heart and lungs. And here's the patient's heart. We knew he had a history of congestive heart failure. And this EF is very low. In fact, you see the mitral valve right here. It's not coming anywhere near the septum. This is a very low ejection fraction. The end diastolic and end systolic volume are not too different from one another. And so we know we have to be somewhat careful with the use of fluids here. Given this, we don't want to push the patient to CHF. And then we do an ultrasound of the lungs, and we see all this socked-in pneumonia actually on the left chest and then in the right chest as well. This bilobar pneumonia going on in the right chest with this in between the fissure there. So we know right off the bat this patient's got pretty bad pneumonia and a poor EF, so we have to be very careful here. So we're being careful with the resuscitation. There's leukocytosis, elevated lactate. We know this patient's septic, and now we're looking at the velocity time integral. We're looking at the velocity of flow of the blood flow that's going through the column of the aortic outflow tract, and the VTI it's in the teens. It's got 25% swings as the patient is breathing in and out. So we know that this patient is actually under resuscitated, and we know we need to keep on pushing them with fluids as best as we can in the setting of a poor EF, but we don't want to run the risk of under resuscitating them. And so we're watching those VTI swing. Meanwhile, we got to get a central line in this patient. We know they're on Coumadin, so we don't want to miss that central line. We do it under ultrasound guidance very carefully. This is the internal jugular vein here, the carotid's over here, and we're just advancing under ultrasound guidance. And you can see here, finally we got that catheter. It's definitely in, looks like it's in the IJ here, the carotid's down here. But to confirm it's definitely in the IJ, we do a subcostal view of the heart, and we give it a little bit of agitated saline, and we see the right side of the heart fills up with those little bubbles right there. And so we know that this is on the venous side, not the arterial side. We don't even wait for a chest x-ray. We see this, and we start infusing norepinephrine to help out with that poor EF is going to respond well to that norepinephrine. So we do that. Now the patient miraculously is up in the ICU and not stuck in the ER boarding, but they go up to the ICU. They actually, with that poor EF, actually ended up with 3 liters of IV fluid. Now the VTI, remember it was in the teens before, now it's much higher. It's 30 with only 9% respiratory variation. Turn down the fluids, and the lactate remains kind of elevated, poor LV function. They switch off norepi and they start dobutamine, and that was helped to improve that contractility, and the patient was actually transferred out of the ICU a couple days later, got off, once they transferred off the BiPAP, and did well. And so I think that was a cool example of how ultrasound was like integral in the beginning, in the diagnosis, helping with the fluid resuscitation and vascular access, those types of things. Another case, this gal was 31 years old. She had cough and syncope. She had fever for 6 days despite taking Tylenol and Motrin. I mean, just Dayquil, NyQuil around the clock, not helping. Went to her primary care doctor, gave her azithromycin for 1 day. No other medical history. Healthy person otherwise. A little tachycardic, definitely hypotensive, still febrile. Again, this is going on 6 days. We hear some scattered bronchi in the lungs, and she's got a little pitting edema bilaterally, and her influenza test comes back positive. Influenza B is positive. And this is before COVID and everything, so this is before we're worried about that kind of stuff. But we do know that influenza can cause, oh, by the way, here's her chest X-ray. It's kind of like a viral pattern. But we know influenza can actually, result in some myocarditis. And so some people are saying, oh, should we get a CT angio? Could this be, a pulmonary embolism? Or maybe we should do an echo and see what's going on. Because if she had a massive PE, we could see, maybe we'd see, RV dilation, or if this was myocarditis, we might see that. And in fact, this is her heart here. It's got very decreased ejection fraction for a patient in their 30s who's previously healthy. This is viral myocarditis right here. You can see that previously healthy person suddenly has this just poor EF. This is the anterior leaf of the mitral valve. It's not coming up and it's hitting that septum. The end systolic, end diastolic difference in the chamber size, not very much. This patient has low EF. You can calculate that EF by dropping an M-mode spike across the mitral valve, and the distance that mitral valve comes to the septum, we call that the E-point septal separation. The E-point is the early phase of the cardiac cycle as opposed to the A wave, which is the atrial kick. So you can see the E and the A, EA, 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 and this is the interventricular septum up here. That M-mode spike goes through the RV, goes through the septum, and then goes across that mitral valve, and we can measure the distance between the interventricular septum and the mitral valve, and that's called the EPSS, E-point septal separation. It measures 20 millimeters. You can kind of see right here. Here's 10 millimeters, 20 millimeters between here and here, right there. Each one of these is 10 millimeters. And so so what's the formula? What do I do with that 20 millimeters? Well, here's the formula. Ejection fraction equals 75.5 minus 2.5 times EPSS. And when you do 2.5 times 20 and take 75.5 away from that, then you get this low ejection fraction, 25%. Here's this healthy person who's influenza B positive, who's got a fever for 6 days and a ejection fraction now of 25%. And by the way, here's her IVC here. She's actually quite well resuscitated. Not a lot of collapsibility here in the IVC. Looks pretty good. So she gets admitted for viral myocarditis. She gets some diuresis based on that plump IVC and her poor ejection fraction. They diurese her. Her edema goes away. And 7 days later, she has this nice looking ejection fraction over here. Bounced right back. So she did well, luckily. And but it was still like, I think ultrasound is super helpful there to help sort of navigate that whole viral myocarditis picture. Here's a new patient, 57-year-old female, shortness of breath for a month. She is a university professor, and she was sitting there in bed 6 looking at me, telling me that she is kind of mildly short of breath for a month. A whole month. Last 2 days, though, got way worse. No chest pain. She's had some right leg swelling, sort of comes and goes. She's on a lot of airplanes. No medications, no recent injuries. She doesn't smoke. Vital signs, maybe a little bit tachypnic. Otherwise, I don't know, really nothing much else. Lungs sound clear, no murmurs. Trace pitting edema on that right leg. I get a D-dimer. It's negative. Now, the clinch of the thing to remember is this 1 month thing right here. She's had these symptoms for a month. It's kind of stoic, sort of ignoring the symptoms, hoping it would go away on its own. Because when you have when you've got a clot, and in the early stages of that clot, the D-dimer goes up, but then the D-dimer starts to go down. So if somebody tells you, yeah, I've had these symptoms for a month, you can't really rely on a negative D-dimer. Normally, we really love those negative D-dimers, but that's more in the acute setting, but not so much in the chronic setting. So I keep looking after, even though the D dimer, the resident order, it was negative. I thought, yeah, it's been a month. She's had this, a lot of risk factors here. So chest X-ray is completely unhelpful. But we go and we look at that left leg, and she's got this non-compressible, partially occlusive thrombus here in that common femoral vein. And so, and I said, right, left. I meant right leg. Sorry, I was looking at the ultrasound, going, wait, this looks like the right leg. Yeah, so the common femoral and the superficial. I say this is the common femoral vein over here, and this is the superficial and deep femoral artery. The indicator is the patient's right. This is lateral. This is medial. This is the right leg. So anyway, this is the clot that's not. This is the common femoral vein that's not totally compressible because there's a partially occlusive thrombus. You can even see the thrombus right there. And so I'm like, okay, short of breath for a month with thrombus in her leg. She's getting a CT scan. And that showed pulmonary embolism, a big one, massive PE. And over here, you could see this is the right ventricle of her heart. Okay, here's her left ventricle, pretty empty. Why? Because the blood is getting stuck in the pulmonary artery because it can't get around the vasculature to get to the left side. And so this is what happens, and with a pretty severe PE, you get this RV dilatation, you get an empty LV, and yeah, so normally the RV is smaller than the LV. In fact, here's the D sign of pulmonary embolism. You can see that septum here in the peritoneal short axis. You can see how that heart almost looks like a D. It should be always round. The LV should always be round, nice and round, and then right there, it's a D. The septum looks like it's straight rather than round, and the rest of the heart there forms the rest of the D. So this is a massive PE, and of course, we admitted her, and she actually did well. But just to kind of remind you, with pulmonary embolism, normally in a heart, the RV should be smaller than the LV, about 2/3 the size. Once that RV starts to get as big or bigger than the LV, that's RV strain. And in the setting of pulmonary embolism, that's a pretty significant pulmonary embolism when you see that. So I know the trend is to, send a lot of PEs home nowadays, anticoagulate them, send them home. But if I saw RV dilatation, that would be a person I would not send home. And Ben Smith puts together this awesome diagram for something called TAPSE. TAPSE is tricuspid annular plane of systolic excursion. And if you haven't heard about it, you should kind of pay attention, because this is something we use quite a bit with PE patients. And we put that M mode kind of thing right over here along that tricuspid annular plane. And then we activate the M mode tracing, and then we see this sort of sinusoidal pattern, and we're going to measure the peak down to the trough. And if it's more than 20, you've got a normal right ventricular function. If it's less than 16, you have decreased right ventricular function, which in the setting of PE could be a real problem. So this patient's got a normal TAPSE. You can see this tricuspid annular plane kind of going up and down in this longitudinal fashion here. And here's the peak, and here's the trough. Peak, trough, right? Peak, trough. And this is a normal looking, probably more than 20. Remember, each one of these is 10. So looks like, from here down to here, this looks like it's almost 30. However, on this one here, this patient's got RV failure, and you can see here that this is the TAPSE here, and it's not going up and down very much. In fact, if you look at this really slow MO tracing, you can see the peak down to the trough is actually only 7.8 millimeters, less than 16. That's RV dysfunction. So positive TAPSE value. What else can cause RV dysfunction besides pulmonary embolism? Well, LV dysfunction can cause it. Sepsis with endotoxins and TNF, interleukins and prostaglandins, causing endothelial dysfunction, capillary leak. And then ultimately hypovolemia, hypoxic pulmonary vasoconstriction can cause RV dysfunction, arrhythmias can, mechanical ventilation. But certainly in a setting of pulmonary embolism, we got curious about what this would look like in patients. Could we prognosticate patients? So tricuspid annular plane of systolic excursion to prognosticate acute pulmonary symptomatic embolism. And that is a very long title because I was trying to make a funny word out of it, TAPSE, PAPSE. All the other authors hated this idea, but I basically forced it, and I love TAPSE, PAPSE, because it's true. It's like TAPSE to prognosticate acute pulmonary symptomatic embolism. I love this. So hoping it would work. The data was okay. I mean, we had like 87 patients prospectively. It wasn't the greatest of studies. It got published in Journal of Ultrasound Medicine. But basically, with this box plot, you can see there was a trend with patients who had very large PEs that their TAPSE values tended to be a lot smaller than patients with small or non-PEs. And these confidence intervals overlap, so this study is sort of not significant, but there's trend there. And it just makes me think like, first of all, it should have been a larger study. But secondly, if, I get a patient with a single digit TAPSE value and in the setting of, PE, I'm probably going to be a lot more careful with that patient than a patient with a TAPSE of 30. So that's PE and TAPSE. What about this patient? Here's another patient that I really almost killed. This is a 38-year-old lady. She was a female. She was a bus driver, brought in by the paramedics, and she had a rapid onset of shortness of breath while she was driving her bus. Yeah, she smokes a little bit. She takes oral contraceptives. Recently started taking those. She was poor snoring. She had a very, very, very large BMI, and she was tachycardic hypotensive. And she was reaching up and grabbing my arm and saying, "I feel like I'm going to die, doctor. Don't let me die." And her dad was in the room. He's like, "Don't let my daughter die." And I was like, "No, it's okay. We're going to figure out what's going on." And I'm reading all this, and I'm like, okay, rapid onset, shortness of breath, okay, oral contraceptive, smoker, high BMI, kind of sedentary, drives the bus all day. I'm going with PE. I think this patient's having a PE. If she codes right now, I'm gonna probably thrombolize her. And so I'm talking to the dad and everything, and I think she's having a PE. But then I look at her heart, subcostal view of the heart, and this is not a PE at all. This is the opposite of PE. This is like it's still an obstructive process of the heart for sure, but it's the opposite treatment, right? You wouldn't give thrombolytics in the setting of pericardial tamponade. I mean, that would make your next procedure very challenging to do, a pericardiocentesis. And so this is really where the ultrasound. I thought I was going to put the probe on this patient and see like a giant RV and just confirm my clinical acumen and push the TPA, but instead I was redirecting the whole case and talking the family into doing pericardiocentesis and pulled like 200 cc's off this heart and a straw-colored fluid. Later turned out that she had lupus, undiagnosed, and when you look at it a little bit closely, once all the dust settles with the stress of the unstable vital signs, yeah, she clearly had a malar rash on her face. But didn't notice that at first. I was really just going after the vitals, and again, the ultrasound clearly made the diagnosis. This is another patient who had been misdiagnosed for a while. This was a 16-year-old female. Her name is Avery, and super nice family. This is the mom, and she's got a twin sister named Chandler. And so what happened was she came in, and Avery, and she was like 3 months of dyspnea on exertion, and she had like an episode of near syncope playing soccer. She's like a really good soccer player and really good athlete. And she the sign out to me was, hey, there's this 16-year-old, I don't know, the mom's taken her to like two different, like a pediatric pulmonologist and a couple of different pediatricians. She's here in the ER because she almost syncopized today. I don't know what's going on, if this is real or not. I got a chest x-ray. It looks normal to me, but I'm just waiting for the radiologist to read it because it's kind of a complicated case. So I was just going to, as soon as that's back, send her home. That was my sign out. So I walked in the room just to say hi to the family, and I was going to do an ultrasound on the IVC to give her a lecture about staying hydrated and things like that. And I do the ultrasound of the IVC. Here's a longitudinal view of her IVC, and there's like a big clot in there. And then here's the short axis view of the same IVC is over here. The aorta is here. The IVC is right here. She's got like a super contracted gallbladder, sort of ADD caught my eye over here. This cute little contracted gallbladder. But here's her clot. So she's got this clot in her IVC. Why would this person have a clot in her IVC? Well, oh, by the way, and then I got a CT angiogram, and she had bilateral pulmonary emboli, and that's why she was having these syncopal episodes and shortness of breath. So all the other doctors missed, including a pediatric pulmonologist. And when I called that pediatric pulmonologist later, and we connected on this case, he ended up doing all these protein CNS studies and all this, and nothing came back positive. The only risk factor was she was taking oral contraceptives. And so, and then the crazy thing is, they wanted to get monthly CT scans on her, and the mom was like, "Oh, I don't want to get these monthly CT scans." They started on Xarelto, and then I ended up just kind of scanning her in my office like monthly using ultrasound, and the clot was gone after like the first month. And I followed her for a while, and then her twin sister gets the same symptoms like a year later, and same diagnosis, almost the same exact looking ultrasound. So They're just really sensitive to oral contraceptives, I think, and that's what caused that procoagulable state and all these symptoms. So, anyways, um, and this is with the color flow on there. So, but yeah, so Avery was pre-med, and we wrote the article up, and I made her an author on the paper. Here's a 70-year-old guy. Oh, this person. This 70-year-old guy, he's at a local restaurant, has a choking episode. Bystander comes along, does the Heimlich maneuver before the paramedics get there. Paramedics get there, and the guy's like looking pretty good. He's sitting up in the gurney when he rolls by me, and the paramedic's like, "Oh, hey doc, this guy had a choking episode across the street. That's this restaurant that's kind of famous to the hospital for people not doing well." And we did some bystander did the Heimlich maneuver, and the patient's sitting up. He looks right. He goes, "Hey doc," and I thought to myself, "Okay, this guy's probably going home pretty soon." But then, like 20 minutes later, one of my residents comes up to me. My resident's like, "Hey, I got this guy. The paramedics thought he's having a choking episode, but I was talking to him a little bit more, and the patient tells me that, he's at this restaurant, and then the last thing he knows, he's on the ground, and somebody's doing the Heimlich maneuver on him." And my resident's like, "I think we got to change our algorithm from choking to syncope." And of course, syncope means we got to go do, an ultrasound to make sure this 70-year-old guy doesn't have a AAA. And I like how the resident's thinking, but at the same time, I'm definitely like a little bit skeptical that we're really going to see a AAA here. So, but indeed we did. This is a really old ultrasound machine that we did this on, one of my first ultrasounds, and big 10 centimeter AAA there that was leaking, and that's that sentinel bleed. He had syncope, and then he has this kind of episode where he's actually doing okay. But those are the people, man, we know we got to get him straight to the OR. So ultrasound really critical for abdominal aortic aneurysms. Here's another AAA here with a big mural thrombus here that dampens the pulsatility. So you've got this, I don't know, 8 centimeter or so AAA here. Here's another one. They have a lot of like this kind of swirly, turbulent blood flow in the lumen there. Pretty typical of it. Here's one we had on Catalina. This is somebody taking it with their cell phone saying, "Hey, I think I'm looking at a AAA here." And I looked at this image. I was out of the country, but we connected, and I'm looking at this image of this video clip that the doctor on Catalina sent me. And indeed, it's like, I told her, I said, "Get that patient off your island right away." It's what dissection looks like here. You can see that flap there, that dissection flap. So sometimes you can pick these up on ultrasound as well. But yeah, this is kind of a near and dear thing to me. This is my uncle. When he was 57 years old, he had a ruptured AAA that was misdiagnosed by an ER doctor on his first visit. He came back 5 days later, and they finally picked it up and went to the OR. And 40 units of blood transfusion later, they saved his life there at EVMS, Eastern Virginia Medical School, and he survived, and he's still alive today. So, but the first ER doctor did miss it, and it was kind of like frustrating for me. He came in with back pain and some hematuria. They thought he had a kidney stone, but it was not a kidney stone. It was this AAA. So just always worry about the AAA. It's the great masquerader. So this is a 32-year-old woman who has just basically arm cellulitis. She's a diabetic, and it just looked like she had just cellulitis on her arm. And so when I went to go do the ultrasound, I thought, oh, well, maybe I'll see like an abscess under there. I always do ultrasound for abscess versus cellulitis, especially if I'm not sure. If it's pretty obvious that there's an abscess there, I just drain it. But if I'm not always sure, then I check. And so in this case, I'm really glad I checked, because what do you think all this white stuff is in here? See all these white dots in here? Yeah, that's air. And her skin was totally intact. And so if you see air under intact skin, that's necrotizing fasciitis until proven otherwise. And so this really, she went to the OR, and she unfortunately did not survive. But this is what necrotizing fasciitis looks like, so you should all be aware of that. If you have a break in the skin, air can get in there. Like IV drug users, a lot of times there'll be a break in the skin. It's hard to tell whether the air under their skin is neck fascia or not. But obviously, if there's air under there, it's kind of neck fascia till proven otherwise. Certainly, though, in intact skin, this is a huge finding. So be aware of that. This is another sign of what neck fascia looks like. A little bit overgained image, but you get this. You see all these white dots here. Ultrasound is very, very, very sensitive for air, more sensitive than CT is. And so just kind of be aware of that. So if you're worried about neck fascia, take a look, and if you see these white dots in there, call your surgeon. This was a 42-year-old developmentally delayed person who was basically nonverbal, who came in with, sort of just not acting right and a fever, and we put a Foley catheter in, and we got urine back, and it was positive for UTI, and we thought, oh, okay, slam dunk diagnosis. There was a little bit of blood too, but we were, treating for what we thought was pyelo. And then when I looked with ultrasound at the kidney, I saw like way more than pyelo. I see hydronephrosis here. And so that really helped, I think, change my direction with the care of this patient. Rather than just hanging antibiotics and forgetting about it, I got a CT scan and it showed an obstructing kidney stone in the ureter. And that's, of course, a very different process now that I have, showering pus into the bloodstream in somebody with an obstructed kidney stone. Very different process. So I called urology, and they took it from there, and the patient had a good outcome. So I think, would I've gotten a CT scan on this patient anyways? I don't know. They're nonverbal, kind of hard to know where they had pain. Definitely would have admitted for IV antibiotics, but it may have delayed the procedure, which they really needed, which was stone extraction. This 56-year-old female, she came in with flashers when she's she sees like in her visual field defect here, she's looking around, she sees flashers. They sort of come and go. Her visual acuity, by the way, was perfect, like 20/20 vision, but just occasionally has a flasher when, like in her visual field when she's looking around. So, I'm thinking, maybe she's got a vitreous hemorrhage. I don't think it's a retinal detachment. I'm not that, it's not like she's got visual loss. She just has some flashers. So this is early on when I first started doing ultrasound, ocular ultrasound, and I wasn't always, that concerned in a patient who could still see that they could have RD. But indeed, this patient has a retinal detachment, even with intact vision. And this is something called a MAC-on detachment. So this is the optic nerve sheath down here, and this is the retina that's detached over here. And it's still intact, though, where the macula is. The macula is lateral. It's lateral to the optic nerve sheath. So the optic nerve sheath is here. The macula is lateral to it. And so to me, this looks like a cobra, this sort of with its body still down on the ground, and it's like head and neck is up here. And so again, here's that optic nerve here, and then lateral to the optic nerve is where the macula is. And so, so if you're looking, if the retina is still attached here at the macula, that's a MAC-on detachment. That is a true ophthalmologic emergency. You need to get ophtho now to see this patient or transfer the patient to an ophthalmologist because they can laser down that retina and save the vision. Once it's MAC off, very difficult to save the vision. MAC on, true surgical emergency. So this is what it looks like here. Here's the lateral aspect of the eye. Here's the medial or nasal aspect of the eye. So this is the left eye. The indicator is the patient's right. And so this is the left eye. And here's the optic nerve sheath. Here is the retina that's still attached at the macula. This is a MAC-on retinal detachment. Okay. Here's another example of a MAC-on retinal detachment on a different patient. Optic nerve sheath looks the same, right? You see this kind of cobra thing up here, but the rest of the cobra's body, aka the retina, is still attached at the macula. Hopefully that's easy to understand because this is a really fun and important diagnosis to make. MAC-on detachment. This was a 17-year-old male who had sore throat and a fever. I wasn't really thinking much about it, but was sick for a good 7-8 days. It was going on for a while, and had some lymphadenopathy, cervical lymphadenopathy, pretty prominent cervical lymphadenopathy, and so the medical student, was going to send the patient home and everything. I said, that's fine. You know what? Let's go in there and have some fun. Let's take a look at the spleen just in case, because, if this turns out to be mononucleosis, acute infectious mononucleosis, and there's splenomegaly, that's like an extra piece of information that we can give this 17-year-old to really be careful with sports for the next, 6 to 8 weeks. And so, indeed, like if you look at this spleen, it is way too big. I mean, we had to range the depth all the way down on this curvilinear probe down to 25, and this is like a 20 something, 21, 22 centimeter spleen here. A spleen should be like 13, 14 centimeters, I think. I have to look it up every time. I can remember that for some reason. But yeah, 22 is way too big. And so I tell the mom, like, and the kid, like, you've got splenomegaly. You need to follow this up before you play sports. You got to make sure your spleen goes back to normal, because if you got tackled or you fell off your skateboard, you could have a pretty bad outcome. So just like one of those little funsies, not critical aspect of using ultrasound, but I do always check that. Here's a 22-year-old male. Someone tried to steal his iPhone. He was fighting with the person. Just a random person came out to them, and then this person just happened to stab them exactly perfectly, like right in that left nipple area. And, just the smallest of small stab wounds. You barely even see it looked like, you could just put a Band-Aid over it and it would go away. I mean, such a subtle stab wound, but it was in the perfect location. So, and the guy actually has pretty stable vital signs. The kid is kind of looking around. He's still kind of angry. This guy tried to rob my iPhone, steal my iPhone from me. But, we did this subcostal view of his heart. This is his liver up here. Here's the right ventricle down here. Left ventricle's here. And here's all this blood and clot in his pericardium. He was stable enough to go to the operating room, didn't get a thoracotomy in my ED, but boy, the stability of this patient kind of threw us off when we first saw this. And we were kind of just saying, okay, we see a lot of stab wounds level in trauma center, but once in a while, someone gets these stab wounds just right, and there really is a surgical emergency underlying it. So, not that this patient wouldn't have got an echo, but I think this sort of just highlights the fact that even though somebody looks pretty good and has stable vital signs, if the mechanism warrants it, boy, you really need to look with ultrasound, because that can expedite things. Because when, the surgeons see this, everything sort of happens very quickly. The next steps go very, very quickly. So. All right, so to summarize, this is, we did a lot here in this quick talk. We saw some ruptured ectopics. I think we saw 3 of them. We saw pneumonia. We did some ultrasound-guided fluid resuscitation, central line placement. We saw viral myocarditis. We talked a lot about pulmonary embolism and tamponade, and we saw an IVC clot, AAA, some necrotizing fasciitis, and retinal detachment. That's me doing ultrasound in Maui on myself. A couple years back, we did a course out here on the poolside doing ultrasound. Of course, you don't need gel. The water is just great. That's a subxiphoid view there of my own heart right here at the sunset. It's good to do it around sunset, not only because the sunset's beautiful, but because you can see the ultrasound screen easier. And one of these days we got to have a really fun pool ultrasound course. I got to arrange that. We got to get organized about that. Maybe this year. Maybe we could do sort of a fun one this year, sort of improvisational one. Either way, excited to see everybody. Hopefully you guys made it to Maui. And if not, see you next year. Take care.